Please listen carefully.
Hello and welcome to Gas Gas Gas, your one-stop podcast for the FRCA primary exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hello, my fellow GasGas collaborators. This is James from GasGasGas, and today we are talking everything you need to know about ketamine for the primary FRCA exam. We're going to look at its properties, its clinical uses, and spend some time on the NMDA receptor and what that gets up to. We're going to pile straight into some questions because I think that's probably the best way to cover this. Doctor, tell me about the NMDA receptor and its function in the human body. Oh yes, the NMDA receptor, found throughout the brain and spinal cord. It is a transmembrane receptor made up of NR1 and NR2 subunits, and it is an ion channel, mostly for calcium, but other cations can transit it either in or out of a neuron. It has a number of additional binding sites which allosterically modulate its action. Glutamate, NMDA, glycine, and a number of others are suggested to bind to it. Oh, I've just remembered, I should have defined NMDA, shouldn't I? Sorry, examiner. NMDA stands for N-methyl D-aspartate receptor. So, this receptor is found on neurons. Even when it's in its open state, if a number of these allosteric modulators have bound and conformationally changed it to be open, it is often obstructed by magnesium in a non-depolarized neuron, i.e. one in its resting state. This magnesium obstructs the flow of cations. Therefore, it means that this obstructive magnesium ion is actually critical to the functional nature of this receptor. In the resting state, the neuron is relatively electronegative, and the positivity of a magnesium cation means that it sits quite merrily in this pore. It is only displaced when the neuron itself depolarizes due to it receiving an action potential sufficient to trigger depolarization. When it meets these criteria, and the pore is in fact open and unobstructed, calcium influx is the chief cation that shifts. However, sodium can also influx through this pore, and potassium can escape from the intracellular environment. The calcium influx is considered the probable mechanism by which the NMDA receptor mediates its physiological function. These are neuronal plasticity, learning, and memory formation. It is also involved in the modulation of pain. Downstream effects of this calcium influx, which I'd be surprised you're getting to if the examiner's let you talk this far, is nitric oxide synthetase, inducing nociception, can cause neurotoxicity in significant amounts, and is probably involved in some of that central pain sensitization. Hopefully the examiner has jumped in well before now and poses another question. Well, that's all well and good. What drugs can you think of that interact with this NMDA receptor? So the chief drug that comes to mind here is ketamine. Yes, tell me more about ketamine, please. So ketamine is a phencyclidine derivative. It is presented as a clear, colourless liquid in a racemic mix of S and R ketamine, often provided either in solution at 50 mg per ml or ampules of 100, 250 or 500 mg as a powder that needs to be reconstituted in saline. Of note regards the racemic mix, S-ketamine is 2 to 4 times as potent as R-ketamine and generally has a more favourable side effect profile. The dosing route for ketamine is chiefly IV or IM, although there is an oral preparation too. Dose-wise, depends on your end goal, be that anaesthesia or sedation or analgesia. IV general anaesthesia is achieved with a range of either 0.5 to 2 mg per kilo depending on your patient and their clinical state. Onset time for that is 30 to 90 seconds, lasting for 5 to 10 minutes. For the sake of time, be nice and succinct with the doses. And an IV analgesic dose is 0.1 to 0.5 milligrams per kilo. The IM doses are higher. So from a pharmacodynamics perspective, its mechanism is actually multiple. Chiefly, it is a non-competitive NMDA receptor antagonist, but it also has activity at the opiate receptor, the muscarinic receptors, and sodium channels on neurons. It generally produces a dissociated anaesthetic due to disconnect between thalamus and cortex. From a side effects perspective, cardiovascularly considered very stable, causing an increase in heart rate and blood pressure, mediated by inhibiting neuronal uptake of catecholamines in the sympathetic nervous system. It does have a direct myocardial depressant effect, though. Ketamine preserves airway reflexes and maintains airway patency, significantly more so than other general anaesthetic agents. It increases respiratory rate, is a bronchodilator, but does cause hypersalivation. It's also noted to reduce pulmonary vascular resistance. It can increase intraocular pressure. Its other neuro effects include an increase in cerebral blood flow and intracranial pressure. However, this is not significant in the context of head injury. Generally, it has a significant neurological side effect of emergence delirium, which can be significantly distressing for patients. That can be mitigated with midazolam. From a kinetics perspective, its oral bioavailability is poor at around 17%. Its volume of distribution is 3 litres, and it is 20% protein bound, which is the least of the hypnotic agents. Its pKa is 7.5. Its unionized fraction is perhaps 60%. It is metabolized in the liver by N-demethylation producing norketamine, which has about 30% of the activity of ketamine. This is subsequently either hydroxylated or conjugated into water-soluble molecules that are cleared renally. Its clearance is 17 mL per kilo per minute, and it has a distribution half-life of around 11 minutes, 2.5 hours for a clearance half-life of plasma, so it redistributes really quickly. Yes, lovely. What happens to a processed EEG if you administer ketamine? If they're asking you these sorts of questions, it's probably to kill time. The processed EEG, when you give ketamine, goes nuts. You probably need to frame it along the lines of for example, BIS index monitoring, your BIS number will go up. This isn't that the patient is more aware, it is a reflection of the disordered neuronal activity that's leading to the algorithm interpreting that as consciousness, or an increased level of alertness, probably a better word to use. So we've talked quite a bit there about the properties of ketamine. I just wanted to touch on enantiomers, mainly because I always forget about enantiomers. So I've decided to break down the word enantiomer for you, using the wonders of the internet because I did not do classics. So enantios in Greek means opposite, and meros, means part, so opposite parts. And this refers to the fact that an enantiomer is the same molecular makeup, i.e. the same molecules, but in a differing position that differs around a fixed chiral centre. What they found is if they divvied up these racemic mixtures into their component two halves and then shined polarised light at them, it would rotate that polarised light in a particular manner, depending on which half you were shining it through. And that's what we're talking about when we're saying S-ketamine or R-ketamine or levobupivacaine. Other drugs that are like this, bupivacaine, etomidate, tramadol. Now onto the practical side of things. Where do we actually use ketamine? Generally, ITU flavoured RSIs and laparotomy flavoured RSIs, and you would be well justified in reaching for it in your patient with an expanding intracranial lesion needing a nice thoughtful anaesthetic that doesn't cause hypotension. The important thing to bear in mind here is that it does drop blood pressure if your patient is incredibly clapped out, because the mechanism by which that increase in blood pressure is mediated is driven by inhibiting reuptake of catecholamines in your sympathetic nervous system. But if someone's literally tipped off the clip, has a systolic of 60 or 70, they don't have much in the way of catecholamines left. So you give the drug at a dose you think is right, and actually all you cause is myocardial depression. Anecdotally, but there's also a paper on it, doses down to 0.25 milligrams per kilo IV for induction have been used. Its other chief use is sedation and resus to pull bones and joints into better alignment, and also you can reach for it in your severely bronchospastic patient. Hopefully they're already on ITU and hopefully they're intubated, because it's a nice bronchodilator. And if you're thinking that you're in that 50p, 20p life-threatening asthma and you're going to intubate them situation, which is terrifying, it's probably a good choice there as well. It does cause hypersalivation though, bear that in mind. A use that it doesn't see much action on in ITU, but I think A&Es have a tendency, is the you've been a fairly naughty boy and you're going to have some sedation now, whether or not you like it because you've got no IV access. Here's some ketamine IM. My experience of ketamine is the onset does seem to be quite rapid in very sick people. They get glazed over, they might make an odd sound or say a couple of words and then space out. But I have seen, entertainingly and interestingly, a professor who had snapped his femur walking along some slightly slippery coastline, doing some professorial stuff, describe an out-of-bodily experience in A&E resus when we were using ketamine to straighten out his leg. He was describing seeing us from above, being like, "Oh, that looks wonky," and then went, "Ow," when we pulled his leg. However, then he said, oh, actually, that didn't hurt. Oh, how very strange. And it was very curious as to what sort of plane of anesthesia-y sedation he was in to explain these things to us. But I imagine his slightly scientific mind was trying to make sense of the situation and was exploring it. It was very interesting. Anyway, getting carried away. In summary, it's an ace drug, especially if you're not going to be waking the patient up because you dodge the emergence delirium. The reason why it's not used as a routine agent is because of that delirium. Pairs really nicely with rocuronium. The next episode is going to be a bit more parochial, and we're going to explore morphine in a similar manner. So my name's James, and you've been listening to Gas Gas Gas. Thank you very much. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.